Hi, my name's Sandy Moore, and I'm a bone radiologist at NYU. And I'm very interested in the question of the diabetic foot, and I was trying to explain before that this has a lot to do with feeling like we're pretty bad at reading diabetic feet, not only x-rays but also MRIs, and we often overread, and we call infection when there isn't any. And the clinicians will tell us that. So what do they see that we don't see that lets them know there's no infection and makes us overcall infection to cover ourselves, perhaps, for the worry that there might be osteomyelitis? So I'd like to discuss some things that I've learned that have helped me to feel a little bit more confident in reading these cases. And if time permits, at the end, I have 2 test cases. Or for hardliners who want to stay at the very end, I'll show you. Okay, so the pedal complications of diabetes have huge societal costs. Actually, the 16 million number here is probably wrong. It's more like 21 million, and about 42 million people with prediabetes, a lot of these type 2 diabetes. And because of the obesity epidemic, this is only getting worse. And about 20% of these people develop foot ulcers. And it's the leading cost of their hospitalization. So it's a very big problem, and treatment philosophies on the part of the surgeons and the diabetologists are shifting. Amputation is the last resort and the worst outcome. This is actually a patient with venous stasis disease, but the SAW holds, which is that if the patient has had 1 amputation, they're very likely to get the second with diabetes, and often these patients will lose the will to live at that point. Therefore, it's kind of important to be really aware of what you're doing when you're making a call on either a plain film or an MRI that might lead to amputation. I know this is all kind of self-given and we know this, but I'd just like to review it briefly. Why do diabetics have problems with their feet? First, atherosclerotic peripheral vascular disease, second, neuropathy, and third, hyperglycemia, and these often collude. So atherosclerotic disease or peripheral vascular disease, much more common in diabetics than in the general population. And I want you to pay particular attention to this line. These patients have cold feet and absent pulses. Their ulcers are red, they're shallow, they do not have callus formation on them, and they're painful. And these patients will often present with gangrene at the toe tips or sometimes around the metatarsal heads. And this is usually clinically evident, which means that they don't come to imaging. We don't see them. Or if we do, we might see possibly just some gas in the soft tissues or atrophic-looking feet. Angiography is the gold standard when there is imaging, and the clinicians decide whether to revascularize or amputate based on the clinical presentation. So in the forefoot, ischemia is much more common, involving the toe tips and often the metatarsal heads, first and fifth the greatest. Occasionally, a patient will be sent for MR when they have gangrene, and what you may see is either destruction of the bone, occasionally derangement of the joints, or even just acute infarct where the bone is very bright because of acute infarct. You may not see a tract, you may not see an abscess. These are difficult cases and you have to give pretty much a differential. But just because the bone lights up does not mean that it's osteomyelitis with infection in the bone. It is possible to have neuropathy in the forefoot, particularly at the MTP joints. And this is just one case of one with dislocation, derangement, and debris. But it's fairly uncommon. You won't see it a lot. So when you're dealing with forefoot issues, you're usually dealing with ischemia if they come to imaging. Okay, hyperglycemia basically makes infections worse than they seem because the patients have poor neutrophil function. And they also have fewer vessels and smaller vessels in their neural sheaths, leading to hypoxia of the nerves and therefore neuropathy. Neuropathy can be in several forms. Autonomic, the patient doesn't sweat, so they have fissures, and the fissures can lead to infection. The patient has an insensate foot with somatic dysfunction. This is being likened to the fat lip you get when you go to the dentist where they say, don't chew for a couple of hours after you've had a filling. You just don't feel that you've just stepped on a big piece of glass, or you don't feel that your bones are beginning to collapse in your foot. And sensory and motor dysfunction, patients, and this actually progresses all the way up to the leg, to the quadriceps, and down into the calf as well. The patient has abnormal ambulation, abnormal pedal stresses, and doesn't feel their feet well. So one of the things the doctors will do with these patients now is have them train for assuming what proprioceptions should be by standing on balloons and things like that. So the pedal neuropath. Clinically, their foot is often painful, but not always. So they may not be insensate in the early stages of the process. They'll usually have unilateral swelling. Usually Charcot and neuropathy does not take place bilaterally simultaneously. They may have swelling, redness of the foot, and a pedal temperature difference of up to 7 degrees centigrade, which is pretty significant. So the clinicians are not going to need to be told that the patient has a neuropathic foot. They're going to know it. The x-ray, when we get that on that foot, is swelling or nothing. Maybe we see a little osteopenia because the bones are hyperemic. When we do an MRI, we do have some findings that will allow us, before things have progressed into Charcot, to make findings that would indicate that this is neuropathy. We see multiple joints involved, we see soft tissue edema, effusions, muscle atrophy, and something called the ghost sign. So generalized soft tissue swelling and edema because of loss of neurovascular tone and vasodilatation. Sometimes in advanced cases of neuropathy, patients will become atrophic and their plantar muscles will become laced with fat, and therefore they contract and they begin to get hammer toe or claw toe deformities. And finally, and this is perhaps the most important one to recognize, this is pre-Charcot, keep in mind. This is a neuropathic foot with a what's called the ghost sign, which is hyperemia within the bones themselves. So the hyperemia isn't just in the soft tissues, it's in the bones themselves, and they're quite bright. If there is no tract, if there is no ulcer, this is very unlikely to be infection, and shouldn't be called infection as such, unless the clinicians give you a very good story for something that is common only about 5% of the time, which is hematogenous infection. Without this, this is just the ghost sign in neuropathy. Okay, we just sort of mentioned quickly the motor changes and the autonomic changes that can lead to ulceration. And with ulceration, the whorl can get into the bone and track into the bone. And the sensory changes that can predispose the patient to trauma that may not be recognized. So, for example, when a person is going from a neuropathic foot and cascading towards Charcot, they may have a twisted ankle. And that twisted ankle may lead them toward a pattern of collapse that becomes recognizable. And all of these things lead to the multiple Ds that we all learned when we were residents: dislocation, disorganization, debris, destructions, and sometimes the bones look dense, but that's usually because you're looking through a thick rim of edematous soft tissue, rather than that the bones are truly dense. In fact, they're more likely to be osteopenic because of hyperemia. How many people get neuropathy of diabetics? And this is all takers, both type 1 and type 2. Well, about a little under 10% at onset of disease, about 30% overall, and about 42% with people who have lived a good 20 years with diabetes. And these are likely to be the older patients and patients with other complications of diabetes, such as retinopathy and nephropathy. How many of these patients get ulcers? About 20%. But not all the neuropaths get ulcers. About 5% of the patients with ulcers have ischemia, and about between 0.1 and 2.5, depending on where you are in the surveys you read, develop Charcot. And you'll notice that my two little Venn diagrams here are separate from each other because these are actually mutually exclusive. I'll explain why. Deborah Forrester, if any of you have read the Radiology of Joint Disease, which is a really excellent book to read and worth rereading, particularly about the question of Charcot, described two colluding theories of Charcot foot. Neurotraumatic, basically the foot is like a fat lip, it walks, it doesn't have sensory feedback, there's repetitive trauma. And the second one is neurovascular, which is that there's an autonomically stimulated vascular reflex with a loss of neurovascular tone. The vessels dilate, there's hyperemia, and weakened subchondral bone. There's actually bounding pulses in the neuropathic foot. So intact vascularity is required to develop pedal Charcot changes. And I know that may sound a little shocking if you've kind of got your atherosclerotic diabetic foot and your neuropathic foot mixed up, which I did for a long time, but they are two different groups of people. How do we classify the Charcot foot when we look at x-rays? Acute Charcot may look normal because it may not have completely collapsed yet. The foot's hot, swollen, looks like cellulitis, maybe things are a little ragged looking. And chronically, you get the findings that we all know and have seen many, many times, what's called the bag of bone, bony debris, fragmentation. Very hard to describe. And we don't do a great job of it, I think. We say, well, it looks like Charcot, it's Charcot. But the clinicians really have better description patterns, and I've learned a lot from studying these. They look at patterns of pedal collapse, and the patterns of pedal collapse have treatment implications that are very helpful and can aid differentiation between neuropathy and infection. So, let me just take a quick minute to go over quick anatomic considerations so things will make sense. There's the medial and lateral columns, the medial column of the foot, basically the first three metatarsals, the cuneiforms, the navicular, and the talus. There's the fore, mid, and hind foot in the divisions for dividing them. And then finally, there's the weight-bearing line, which is a line between the plantar aspect of the calcaneus and the sesamoids. When bone dips down below this, it has the potential for developing what's called a rocker, with a rocker bottom deformity. And when that happens, an ulcer may develop over that level of the bone. So when there's collapse in here, that's the risk, when things fall below the weight-bearing line. Lou Sean, who's down in Baltimore, has come up with a system that I really find interesting. There are other orthopedic systems, but this is the one I'd like to go over. And it describes mid and hind foot patterns of collapse. There are other patterns that address the tibio-talar joint and also the forefoot, but these are the ones I'd like to go over. And he has subsets by degree of severity that are kind of labeled here, but I don't think it's important to learn them. I have found that I cannot memorize them. I'll look them up if I think I need them, but it's enough, I think, to recognize the major pattern type. So there's the Lisfranc, the Naviculo-cuneiform, the Peri-navioular, and the transverse tarsal. We'll go over these. Okay. So the first is the Lisfranc. This is the most common. You've all seen it a million times. Starts out with hallux valgus, the forefoot abducts a little bit. And then you develop over time a medial rocker with a medial cuneiform and possibly an ulcer right over that location. And also the metatarsals begin to lift up relative to the cuneiforms. And although the talus stays in plane, so you don't have the talus diving down, the calcaneus will basically lose its inclination because of the pull of the Achilles, and you may develop a medial cuneiform rocker at that time. That's early in the Lisfranc pattern. So you start out with hallux valgus, and then you begin to shift your metatarsals, and your medial cuneiform can become a rocker. Here's an example of an ulcer and a tract leading to the medial cuneiform in a patient who has a Lisfranc fracture deformation fairly early in the game. Later on, you develop lateral rockers because you have the shift of the metatarsals. And your lateral rocker can be your fourth or fifth metatarsal base, or your cuneiform, your cuboid, usually. So here's an example of bone just hanging out in space that has the potential for falling below the weight-bearing line and becoming a rocker. Here's another example of a cuneiform that became the weight-bearing bone below the weight-bearing line. And you can see the ulcer actually leading to the level of bone. So if I were reading this, even if this bone didn't look ragged, I would say there's an ulcer with an air-filled tract extending to the cuboid, and this looks like a rocker because of the flat foot deformity that's created here. And therefore, I think that this is a case where you'd have to worry about possible osteomyelitis in that cuboid, but maybe not all of the bones. Okay. The second pattern is one that we see a lot, but we don't know how to name it. I find this sometimes a little bit difficult myself. It's the Naviculo-cuneiform. And these bones stay in plane, but you begin to sag in here at the beginning, between the naviculars and the cuneiforms. Sort of just a little saddling or sagging at the beginning of this. And then over time, you develop a lateral rocker, usually under the fourth and fifth metatarsal cuboid joint. And here's a CT that shows this pattern. You can see that there actually is no rise up of the first metatarsal relative to the cuneiform. So this is not a Lisfranc pattern. This is a Naviculo-cuneiform pattern where the basic breaking up of the ligaments is right in here. And the bone is hyperemic. I've already said that. So what happens is a little bit like what happens with children when they get internal derangement of their knee. They don't tend to actually tear their medial collateral ligament. They flake off the femoral attachment of their medial collateral ligament, or they flake off the tibial attachment of their ACL. The same thing happens, I think, a lot of times with the hyperemic bone that we have with neuropathic foot. Another thing that takes place, which is kind of interesting, is that the bones begin to fit together a little bit like a jigsaw. They get uneven edges because they've flaked off portions. And I think that that may wind up being for a short kind of a stop before they collapse again, and they continue to collapse again. And the more you look for this, the more you're going to see this jigsaw pattern. The third, which is fairly common also, second to Lisfranc, is the peri-navicular pattern. And it starts out either with a navicular AVN or fracture. And having a subchondral cyst or perhaps a stress fracture of the navicular is not uncommon, but if you have it in a neuropath, you have to be aware that this patient may be moving toward the peri-navicular pattern and may comment on that. Over a time, you will progress with fracture or AVN and fragmentation of the navicular. And it looks something like this. And I just want to also call your attention to the pattern of marrow edema here, which is sort of radiating out in a joint-centered way from where this fracture is. So over time, what happens is the metatarsals and even the cuneiforms sort of crawl on top of the talus, the head of the talus and the neck of the talus, and you have a complete collapse of that medial column that we talked about. One of the things that Lucian does in his description is he describes these sort of migrating rockers that start out medially and then head laterally and then shift back centrally. I think that given that we have cross-sectional imaging when we look at these cases and we can look to see which bone it is, we don't really need to describe it in that way. We can say which bone is forming the rocker. It's easy enough. So here's an example of a CT with a peri-navicular pattern, and you can see this fragmented bone. These fragmented bones just crawling up on the neck of the navicular, of the talus here. And again, this jigsaw kind of an appearance of bone trying to fit into bone to make a stopgap to the collapse of this foot. Here's another example of an X-ray showing the same thing. If this is a weight-bearing, this is a weight-bearing X-ray, so if you draw your weight-bearing line, you're going to see that there's a flat foot deformity with loss of the calcaneal inclination, but also these dorsal fragments that are just sitting up on top of the talus because of the collapse of the medial column. Here's another example, same thing on an MRI of navicular fragmentation and a cuboid rocker. And under the cuboid rocker, the ulcer. That's what you have to be concerned about, and that's really why you have to give gadolinium. You don't want to give gadolinium because you want to see if the bone enhances, because neuropathic bone will enhance. And any bone under stress with a lot of fragmentation is going to show enhancement. The reason to give gadolinium is to see if there's actually a tract leading to the bone. And to look at the soft tissue changes around the bone, because that will shore up where the real action is and which bone is the one in question that may be infected. The fourth pattern is one that you may have seen sometimes with posterior tibialis tendon tears, which is basically you begin to have an abduction of the fore and midfoot, and the talus may become even completely uncovered by the navicular, as you can see beginning to happen here. And a lot of things happen. This is more of a hindfoot pattern than a midfoot pattern. The talus begins to dive down. It becomes plantar grade. And the calcaneus also loses its inclination. So this is what you'll see on X-ray. Completely dislocated or partially dislocated talonavicular joint with an uncovered plantar grade talar head. That itself may become the rocker, the talar head. The patient may be walking on their talar head. And this X-ray, this is an oblique X-ray, actually goes with this X-ray. This is the lateral of the same patient. And you can see that the talus is very plantar grade. And you've lost your calcaneal inclination, so I guess the talus, the cuboid, and the calcaneus are all vying to see which one will become the rocker or the bone that's going to create ulceration over it. I want to say something about that ulceration too. Do ulcers happen from the outside in or the inside out? It isn't well understood. It used to be thought they happen from the outside in. A patient gets a fissure, and then the world crawls through it and sends microbes to the bone, and you get infection. Then it began to be thought that it's more or less like a decubitus ulcer that you might have over your sacrum or your ischial tuberosities, where there's pressure and there's ischemia in the soft tissues, and you eventually break it down, and then when you reach the level of skin, you can have ingress of organisms. Another theory that is being bandied around a lot now amongst diabetologists is actually a reverberation between the pressure from walking on these and the pressure of the rocker, where the ulcer will form over time. But you may be able to see an incipient ulcer formation. I have one example for you to show. How do the doctors deal with this? The textbook approach to Charcot is really changing. It used to be basically immobilization. This is a total contact cast of a patient whose foot is collapsed. It will last for several months. The patient is immobilized, doesn't walk on this, doesn't bear weight on this. What's going on now is that if the foot can't be braced well, if they have recurrent ulcer that doesn't clear up, or painful arthropathy, now they're beginning to fixate the Charcot feet more and more. And the remarkable thing is they're beginning to reshape these rocker bottom feet back into a normal pattern. This can involve either internal or external fixation. The internal fixation, such as you see here, where the entire, this is a pan-talar fusion, is stronger and more precise, but you can't do it if there's infection. So if there is an ulcer, you would not do this kind of fixation. And it's not meant to be done for mobility of this joint. This is a fused joint. It's not going to be mobile, but for correction of ulcer formation and to have this person keep their foot. And newly being practiced at Hospital for Joint Diseases, where I work, is external fixation in the Charcot foot with ulceration, where it can supplement internal fixation or actually be used in lieu of it. And it's a salvage. And this is an example of a patient who's actually, this patient had a infected talus due to hindfoot Charcot. And after the fixator was removed, you can see these where these little pin tracks were, there's solid osseous fusion of the tibia with the hindfoot. So the patient can't move this ankle, but they can walk on this. It's nice solid fixation. So if you see that the patient's had on a Lizeroff frame, they've had Charcot foot, then they've had a Lizeroff frame, don't call these areas of indistinct bone infection. You'd be overcalling. The Steinman pins are usually placed proximal and distal to the ulcer site when they're fixing these in order to stay away from directly tracking infection. And this is what the x-ray will look like if you get a patient. They're hard to read, but at least you know what you're seeing. Here's another example of a patient preoperatively with a downturned talar head, probably with a transtarsal pattern, and a rocker bottom deformity with an ulcer. And post-operative, the hardware was removed, and there was a nice solid calcaneocuboid and subtalar fusion, and the rocker bottom deformity was corrected. These patients often do very well after this. So the question that we have, and this is a real Friday afternoon question. Somebody will send you the diabetic patient or the patient with a decubitus ulcer on a Friday afternoon. Am I not correct? Okay, and then you have to make a decision as to whether there's osteomyelitis, and these are hard cases that often take a long time to read. So is it osteomyelitis you're looking at, or is it osteoarthritis with a vengeance, which is again a Deborah Forrester term, meaning Charcot joint? And so we look at the x-ray and we say, boy, it looks pretty bad. Maybe we better get an MR, and they say, do it right now. I'm worried about this patient. Okay, so the MR will usually get us into worse trouble than the x-ray already did. Is this osteomyelitis? MR is requested. What are you going to do with it? Okay. So there's a lot of similarities between Charcot and osteomyelitis, not only on x-ray but also on MR. In fact, perhaps more similarities. You get subcutaneous edema, you get joint effusions, you get fluid collections that can have enhancing margins, and bursas and adventitial bursas. You get marrow edema that's out of control, and soft tissue and marrow enhancement. So are you going to call every time you do an MRI of a Charcot foot infection? So here's the rules that have helped us. First one is a mid or a hind foot that's a Charcot foot without a rocker bottom deformity is not likely to ulcerate. Keep in mind that hematogenous infection is going to be in about 5% of cases. I have to accept heel ulcers from this, by the way. It's kind of a different category. Second is with inversion and collapse of the plantar arch, which you can recognize and describe the patterns of, you develop the possibility of an ulceration. And that's the bone that's going to be the most likely to be infected, what your rocker is. So here's an example of a patient with a Lisfranc fracture deformity. You can see a big wide space between the first and second metatarsals. Joint-based edema, but there is an ulcer, and the ulcer tracks to the first cuneiform, so you would have to be very concerned about that bone. And that's also why you want to give Gatto. So you want to see if the soft tissue infection tracks to the bone itself. The second rule is use location. It's very helpful. In the forefoot, you're more likely looking at ischemic disease, although neuropathy is within the realm of possibility. And in the hindfoot, with the medial cuneiform and the lateral structures, particularly the cuboid, you're more likely looking at neuropathic disease, and you want to take a good look on your cross-sectional imaging at where that bone is relative to the weight-bearing line, and also where it is relative to an ulcer, if you can suss out an ulcer. It's a good thing to see the patient and see where their ulcers are if you can. And I also included this little circle here to remind you that you also may have heel ulcers for reasons of pressure in debilitated patients, which is a different entity. These rules really work. This was a patient who had a big ulcer on the dorsum of her foot with some pus, and they sent her to me, and I looked at it and I said, goodness, this is an ulcer, this is a tract, it's tracking down to bone. This patient has some kind of neuropathy with fatty atrophy of her muscles. What is going on here? And I called the doc and I said, you know, for all practical purposes, this is a Charcot joint, but the ulcer is on the dorsum of the foot. And the doc said, that's right. She's crawling on this foot because she has spina bifida. And this was the weight-bearing aspect of the foot with the rocker deformity here. So these rules actually really work, even in unusual cases. The rule 3, this is rule 3, or this sort of set of rules, and it's the most important, I think, of them all. Charcot is articular-based. It has an articular epicenter. It involves many bones, and you may see subchondral cysts, whereas osteomyelitis has a marrow epicenter with focal and fewer bones involved. Of course, the two can coexist. So one thing to look for when you're looking on your images is for subchondral cysts. They are usually a sign of Charcot, and they're not necessarily a sign at all of infection, although I would be worried here for infection if this showed an enhancing tract. So you look for subchondral cysts. Now, here's the first of, how are we doing for time? We doing all right here? Here's the first of 3 test cases. And see if some of you may have interpreted this the way that I think may be correct to begin with, but see if you would interpret this a little differently now. So here's the SAG T1, and you can see that maybe the first metatarsal is a little high riding there. Maybe we're starting to get into a little bit of a Lisfranc here. And then you can see the fragmentation and the edema in the cuneiforms at the metatarsal, tarsal-metatarsal joints. And maybe there's a little bit of a rocker in here. So Charcot, easy, right? And you can pretty much say this is probably a Lisfranc pattern. And there's some muscle atrophy. On the sturs, the bones are just red hot. They're blazing. Okay? So, osteomyelitis?
No.
No. Okay. Why not? No track? No ulcer. Okay. No rocker, really. There's a little bit of a beginning incipient rocker bottom deformity because of the collapse that's taking place with the Lisfranc. But no rocker and no osteo. So all of that marrow edema is Charcot changes because the hindfoot's collapsing. It makes sense that there would be. And also, it's articular epicenter. Here's another case. I actually showed you a coronal and a sag of it before, a coronal and an axial of it before. So this patient has no displacement of their bones and no fragmentation. They have marrow edema. It's probably a Naviculo-cuneiform pattern, but no rocker, no ulcer, no tract, no abscess, no phlegmon. So this is the ghost sign in a neuropathic foot that hasn't yet even developed anything that would show up on X-ray. So strive to recognize neuropathy in early Charcot, but not to overcall. The take-home lessons here, and then I think we have time for a couple of test cases if you want, are vasculopaths and neuroarthropaths are usually, although you can always find exceptions, but usually mutually exclusive subcohorts. Charcot requires intact vascularity and a precipitating event such as stepping off the curb the wrong way in intact bone. However, if you read sensitively, you may be able to predict to the podiatrist, this patient has bad neuropathy, they've got a ghost sign, they're heading towards Charcot. In other words, you may be able to catch the canoe before it goes over the falls. Location. Vascular paths are more in the forefoot, Charcot more mid and hind, although there are exceptions and overlaps. And if you can recognize the patterns of tarsal collapse, the lis franc at the tarsal metatarsal joints, the naviculo-cuneiform, the peri-navicular with the fragmented navicular, and the transtarsal with the talus popped out of the navicular, you may be able to make some sense out of the rocker bottom pattern that you're going to see, and also read your x-rays a little bit more sensitive. No ulcer, in most cases. Obviously, you have to follow your own wisdom, but in most cases, there's not going to be osteomyelitis, even if there's a heck of a lot of soft tissue edema and marrow edema around. And here's two cases we had this week, and I just picked out a few images here. So we're at the first tarsal metatarsal joint on this stir. What do you all think so far? Charcot, lis franc, probably, right? Okay, that first metatarsal looks like it's lifting up from the cuneiform. Shouldn't be doing that. And then here's the stirs. Loads of marrow edema. And it's joint-centered, right? The joints look pretty bad. They have little areas of sclerosis. So loads of marrow edema. Infection? Yes, no. No? No ulcer? Yeah. Patient may be heading toward it, but they haven't got it yet. Okay, here's another case. So big marrow edema, no ulcer. No osteo. Second case. So we're starting out immediately here at the first tarsal metatarsal joint. And you can see a lot of fragmentation of the tarsus, particularly the, this is probably a Naviculo-cuneiform pattern, but things are so ripped up here it's a little hard to really pin it down. And you can also see this interdigitation of bone fragments, and that's actually what the pathologist uses in making the call of Charcot. If you're looking at, say, a Charcot knee in a patient with tabes, or a patient with a Charcot foot that for some reason or another there's a mooted diagnosis and they need to be looking at the pathology, is they look for synovium with bone fragments in the lining. Okay, does anybody see anything that looks sinister? There's an ulcer. But this is T1 and the marrow looks pretty good in signal, right? Okay. So then we do, here's the, this is actually I think post-contrast, pre and post-contrast, and you can see that the metatarsals are getting ready, crawling right over the top of the cuneiforms here. So this is midfoot collapse, medial column collapse. And then here's a stir image and another stir image. Not much in the way of marrow edema, right? Here's the post-contrast, the one single post-contrast image. So what do you think? Which bone would you tell them that if they think that they need to explore, they should go after? Cuboid. The cuboid, right, exactly. Okay, so you're using pattern, and you're using not just marrow signal, but what's happening on the post-contrast images, as well as where the ulcer is, to make your definition of where your most suspect bone is. The patient may have a huge amount of marrow edema otherwise, and only one bone in question, right under the rocker, or right at the level of the rocker. So that pretty much sums up what I'd like to put across. Does anybody have any questions they'd like to ask?
Most of the patients we see at my hospital are probably, that we do the MRs to the foot, of the have peripheral vascular disease.
Yes.
And we never use gadolinium because they don't have ulcers.
Yeah.
Is that reasonable?
So do you see infection in their forefeet mostly, or where do you see it?
In the phalanges or the tarsals.
Yeah. Do you see destroyed bone, or do you see intact-looking cortices when you see that?
We just look for edema, basically.
Mm-hmm.
If I see the edema, then I'm able to call it, generally call it positive.
For osteomyelitis?
Yeah.
Do you think you might be looking at ischemic bone sometimes?
Well, the bones are ischemic.
Yeah.
But they can't be hyperemic. Like you say, the Charcot patients can have hyperemia.
Mm-hmm.
And that's why you may be seeing edema, and they have bounding pulses. These patients don't have no pulses.
Yeah, right. So
So they can't be
That's absolutely correct.
So when I see the edema, I call it osteomyelitis.
What you may be seeing some of the time, and if you see destroyed cortex and a tract leading to bone, you're probably correctly seeing osteomyelitis. But if you see intact skin, and these patients may have distal ulcers that may or may not tract to bone, but if you see intact skin and intact soft tissues, you're not giving gatto, so you don't have the help of finding a tract. What you may be seeing some of the time there is not actually osteomyelitis, but acute ischemia, because there's a differential for marrow edema.
Well, if we're
Yeah.
not sure, we'll get a three-phase bone scan.
Yeah,
So
yeah.
Why is the marrow edema absent? Is it simply periostitis, really, rather than osteomyelitis? Or
In
what
which,
accounts for the absence of marrow edema?
in this case, it's,
Osteomyelitis. Yeah.
in this case, in this last case, it's probably chronic Charcot. It's chronic Charcot, but the patient's developing an ulcer because of collapse of their hindfoot. So they're no longer having any edema in their foot because they've quit the hyperemic phase where they're collapsing. But they've got a rocker bottom that is developing and beginning to reverberate between the cuboid rocker and the soft tissues, and it's an ulcer is in the incipient phases of developing here. Yeah.
Do you ever use three-phase bone scan?
And we've been using Nutrispec studies, doing Nutrispec studies, and we're finding the same kind of gray zone sometimes that you find with MRI, where things light up that in a Charcot foot without infection necessarily, because they can have soft tissue edema as well, and so we're finding them to be correlative, but maybe giving a lot less anatomic information than you get from an MRI.
Do you have a spec
Yeah.
CT scanners that correlate to Nutrispec to the anatomy?
Not where I'm reading them right now, no. Yeah. It would be a good thing to have. Do you?
No, I want one.
Yeah. Yeah. Other questions?
Well, how do you read these out? Do you say diagnostic of osteomyelitis, highly suspicious for, maybe a little suspicious for?
Okay, so
What are your gradations of?
when I have
paper?
a lot of marrow edema and it's in a joint-related pattern, I don't have a rocker, and I don't have a tract, and I don't have an ulcer on post-contrast, then I'll say this finding is consistent with Charcot. Okay, active acute Charcot. If I have acute Charcot and a rocker, and the bone directly related to the rocker has a tract leading to it, I say this is a Charcot foot. There's a lot of marrow edema, but the bone in question is the rocker. And if I have no marrow edema, like the last case we looked at, or just a little bit of it, but there's a tract and an ulcer, I'll make a big point of exactly where it's heading, where it seems to be heading, and say this is the bone that needs to be watched, and if there's a plan for debridement, this is where I'm concerned, and I'll label it as such. And our surgeons have been telling us that we have pretty good correlation. We haven't really run a study on that any time recently, but they're saying that they also use the rule, no ulcer, no osteo. And there are rare exceptions. We've seen children with hematogenous infection, and they're a whole other, can of worms, yeah. But with a diabetic adult, these rules tend to work pretty well, and it allows you to look at something that would make your hair stand on end in the past and go, I know what this pattern is. There's not a real rocker bottom, and gee, I don't find, looking very carefully, an ulcer or a tract. So I think that this is what it is. You can always make a proviso while you're getting your sea legs around it. I don't see an ulcer or tract. If there is one clinically, this can be correlated with the findings on the study, and then if the clinician wants to come down and discuss it with you, they're much more likely to discuss it if you call osteo and they don't want to do surgery than the other way around. If they think the patient has osteo, they'll do surgery, regardless of what you say. Please.
For all the money and time we're spending with this, we've seen patients over several years now where we're saving the foot.
Yes.
Okay, and are you going to be showing images in the future of what the foot looks like after it's been treated, disorganized?
Well, we did actually. Those are those.
Where you don't have infection or a lot of swelling and edema. Is that coming
The ones that are where they're using an Elizroff device and doing external fixation and reshaping the rocker bottom foot, there's only a couple of years of clinical experience with this. And so you're going to have to take it out further to
So
see
the
if it
physician
holds
will
over a
say
long
to the
period of
foot,
time.
they'll be working on it, not
Over
amputating it.
time.
That's where we're going.
That's where you're and you're hoping to give a good sensitive reading that doesn't overcall.
I mean, we're
That's
putting a lot of effort
specific
into
to.
this. I wanna
Yeah.
make sure it's-
Yeah. Even if you save a foot that would otherwise have, say, 5, 10 years ago been amputated right away, rather radically, and you save it for 3 or 4 years, that's a very significant addition to the person's life, I think. You know, because they're becoming more conservative, and they're whittling away less at the foot in order to keep as much of the foot as possible, because once you lose one foot, the other foot begins to have abnormal ambulation as well. And even if it doesn't become a Charcot foot, it can have problems because of weight bearing, abnormal weight bearing, et cetera.
What can you do to stabilize? Is there anything they're doing to stabilize very early changes, like if you see?
Well, they'll do, early on, they'll do the total contact casting and the non-weight bearing. And then if a person's still developing ulcers or painful neuroarthropathy, then they'll begin to do either internal fixation or external fixation, depending on if the patient's infected or not infected. If they're infected, they'll only do external fixation.
If they're casting for a long time, aren't they really losing a lot of bone during the time?
Yes, it's true, yeah.
It just makes.
But the problem is you're trying to stop a canoe when it's like right on the edge of the falls. You're trying to keep it from getting any worse and let it stabilize and then begin to knit back together. That's the general plan. And if the person has progressed onto a rocker, they're going to develop an ulcer, most likely going to develop an ulcer, and then they're going to be inviting infection as a result of that. So that's something that really complicates the problem for these patients.
What's the pathologist used to say yes or no? Do they see germs in the bone and it's not put there during surgery, or what do they do?
I'm not sure I know the answer to that. I think they look for, when they're looking for Charcot, though, they're looking for synovium with bone within the lining of the synovium, not necessarily infection. You know, the clinician will know when they do the surgery if the bone is mushy, if it's you know, if the bone has osteomyelitis as well. So.
Do you give GAD on all of them? And the enhancement of the marrow doesn't hold anything. It's really the soft tissue changes.
It's the soft tissue changes that tracks the abscesses, the phlegmons. It brings out the ulcer if you couldn't see it otherwise. It's extremely helpful to examine the patient, but not always practicable in everyday practice, particularly if you've got a center 6 miles from where you're going to be reading the case, where the study's being done.
They invariably show up with an enormous bandage.
But they can tell you where the ulcer is, and they could even tell your tech, if you trained your tech, to say exactly where's your ulcer. Do you have an ulcer, yes or no? And if so, tell me where it is, and then they can put a vitamin E marker. It's helpful to know where the ulcer is, you know.
Hopefully you have some plain films occasionally, no matter what.
Can't always see them on the plain film either, unfortunately. But if you can examine the patient, it's a 2-minute examination. If you know they're going on, just say, do you have an ulcer? If so, show me where it is. That's all you need, you know. But remember, infection is often worse than it seems, so they may have a little superficial ulcer and deep have a lot more infection going on. Yeah.
Are you acquainted with an article that appeared, I think, a few months ago in Radiology with some new criteria for osteomyelitis diagnosis that involved insisting on a complete confluence of a large area of low T1, high T2 signal intensity and enhancement within the bone?
Yeah, I think I saw that.
That sort of is a revision of at least what I had understood to be the old criteria of equal enhancement of soft tissue surrounding the bone and of the bone in fat saturated images. And I wonder if you, in your experience, that really has, if that's the true way that we should be making that diagnosis in the diabetic?
I haven't found that low T1 signal or high T2 signal always guides me in the Charcot foot. And that's specifically sort of what I'm trying to address here. I think it may be a little different if we're talking about the forefoot with neuropaths. I think that obviously if there's no marrow edema, there's no osteomyelitis, even if there is a tract and ominous other findings in the soft tissues. And you can use the low T1 signal sometimes to really have a better sense of specificity of where the abnormality is, because on the STIRs, things can really just light up all over the place. In terms of enhancement, I think there's been some really nice new work that's been done by Bill Morrison at Jefferson, where he's looking at dynamic enhancement to see if there's a difference between Charcot and infection, if the dynamic enhancement is a little bit different. I don't think they've yet come up with anything that gives a hard answer, and most of us can't really run dynamic series on top of everything we're trying to do. It's enough to try to give Gatto and make a reading on the case. So how do you find that you use
Well, I think
that wisdom?
That I have not been using gadolinium very much
Mhm.
for practical purposes,
Mhm.
just because of practice constraints.
Mhm.
And I have occasionally felt that it made more obvious some sinus tracts or small fluid collections that
Mhm.
may be very small.
Mhm.
I guess they might appropriately be called sinus tracts. Although I'm not always sure that that little fluid collection that I'm seeing is a tract from an ulcer to the bone.
Yeah, if you try to track it in 3 planes if you can, but you can't always. Yeah.
So I'm not sure that it's ever really changed, in effect, my impression
Mhm.
for having given it.
So if you see a tract to bone, if you see an ulcer, an enhancing ulcer or callus, and you see a tract to bone, that doesn't change how you make your call?
That would, but now I'm concerned because now this article is telling me that if all I see is enhancement of the periosteum or a superficial layer of the bone, then I'm not allowed to call that osteomyelitis.
Well, you can get a periosteal reaction in a bone that's undergoing Charcot changes, or that's in the stages of the stress of collapsing. So you don't get so many, you don't get much periosteal reaction in the hindfoot, but you may get it along the metatarsals. That's where you're going to pick it up. So periosteal reaction by itself is not something that I would use as a call to try to differentiate infection from neuropathy. Actually, a couple of these cases that were definitely just neuropathy had periosteal reaction. Yeah.